So again, okay. Again in travel costs, what are all the different travel costs? One by one, maybe. Bus, car, train, flight. So yeah, now these are the different costs. So while you are doing planning, what you will do, you will list down all these areas. For example, from your home, you will catch a taxi or auto. Okay, that will also add to your plan, your trip cost, right? After that, you will catch bus or train or flight. Then again, you will eat some food in a flight, or either you will go to the hotel and you eat. So the cost varies again. So it depends on you, right? Who is going it or who is leading the whole team. Depends on them. The different costs will come, right? So similarly, in pharmacoeconomic evaluation studies also, you will look for the different costs. Some are direct costs, some are indirect costs, some are intangible costs. Direct costs are something like, to get a service, health service, what are all you are investing on, like OPD charges, IPD charges, right? Medical expenses. Here, even you consider the travel costs also. How much cost you have to invest to go to the hospital, okay, and get these services.
Yes, sir.
So to utilize this service, what are the different costs that you are even when you if you are accompanying a patient, you have to do leave, right? Even that cost. You are availing something. So either daily wage laborers, if they quit the job, they will not get the expenses. So these costs also can be included, okay, in the assessment. While collecting the data also, you have to include all these different kinds of costs in your evaluation. So similarly, the clinical outcomes. So clinical outcomes, anyway we get clinical outcomes from the RCT studies. So we rely on either RCTs or systematic review meta-analysis, where they will show different outcomes possible in that particular disease. For example, if you look at some treatment to cure stroke patients, after giving medication also there is a chance of occurring MI, right? Myocardial infection or angina. So these will be listed in the published literature. So you have to look at these outcomes possible for any particular disease X. Let us say diabetes. So now we are treating either with sulfonylureas or metformins. What are the different possible events? So these will be documented in the RCTs. So you look for those outcomes and you can utilize it. Similarly, you will also look for the adverse drug reactions and then you also look for the humanistic outcome, that is patient well-being or quality of life. So the major measure that we look in the pharmacoeconomic studies are quality of life. Okay. And then perspective. So now people have different perspectives. Some people wanted to take bus, some wanted to take train, so some wanted to take a flight. Okay. So similarly, so based on that cost varies, right? So similarly in pharmacoeconomic evaluation studies also, based on your perspective, what are the different costs that you have to collect and include in your analysis will vary. I'm trying to make it as simple as possible. Okay. So for example, payer's perspective. If there is an insurance company wanted to perform an economic evaluation study, okay. So what are the different laboratory investigations? What are the different medications they are ready to invest, ready to reimburse the patient? Those costs only they will consider while doing the economic evaluation. Okay. And similarly, if it is a health system perspective or provider perspective, if government is investing, government wanted to provide some services free of cost. So government will look at what are the different treatment modalities they wanted to provide to the patient. So only you have to consider those costs. So that is the perspective is also very important. So similarly, patient perspective. So if it is a patient, few patients they wanted to get admitted in the general ward. Some wanted to get admitted in the deluxe room or AC room or non-AC room. So accordingly, you have to invest the cost. So OOP is out of pocket expenditure. Out of pocket expenditure is basically how much you are investing from your pocket. Okay. So how much patient is ready to avail a particular health service to get treated for the disease. Okay. So accordingly, you have to include the indirect and intangible costs also. Intangible costs are like again something like pain. Sometimes you may have to score the pain, how much pain they are okay, or how much they are not ready to bear the pain. Okay, so accordingly you have to calculate the cost. So there is something called societal perspective. So this is the broadest of all different perspectives that are available in the pharmacoeconomic study. So here we will include all the direct and indirect costs. So direct costs are like whatever you are paying to the hospital to avail the service. Indirect costs are to reach the hospital, like transportation or wages lost due to hospitalization. So something like that. So you have to list down all the prices. So something rest of the three are narrow, and the societal perspective is the broadest one of all the perspectives. Okay. So now what you can understand, even the insurance companies, they need this economic evaluations right now. Okay. If you learn this, even you can approach some medical device companies or insurance companies also for the job opportunities. Like how I worked in Medtronic. Have you heard about Medtronic? Medtronic. So Medtronic is a medical device company. Now it's the world's largest medical device company. They are the inventors of stents and pacemakers. Okay. So even they need economic evaluation. So what is model? So when you read about any pharmacoeconomic studies, you will often come across with this word called model. Model is basically a simplified description or representation of the reality. For example, let us take the same example. You are going for a trip. So you have to start from house, take an auto, then you reach out to the bus station, and from there you will go to your destination, or you have to get down at some point. Again you have to take one more, and again you will come back. So this is the events that are there in your trip. So similarly in disease also, there is something called natural history of disease. You know natural history of disease? How the disease is progressing from one stage to another stage. So in cancer patients, stage 1, stage 2, stage 3 are there, right? Right? So this is the progression of the disease. So when you read a disease with some medication, what are all the possible events that can happen? Okay, that you have to capture from the literature and you have to develop model. I will show some examples. So usually the model would be decision tree or Markov model. These models we use in health HTA, but otherwise there are different other models also. So these are basically extrapolating the data beyond the trial. Trials are something, they are very difficult to conduct. They are challenging because of the ethical issues involved, and they are very costly as well. Okay, conducting the RCT is very costly. Have you ever read any trial that conducted more than 10-15 years? Those who are reading the publications. Any RCTs beyond 10-15 years? No, right? So hardly any study would have been conducted more than 15 years. So this data, this 15 years data, we can use till the patient reaches the death in economic evaluation studies. So that is why they are gaining more and more importance nowadays to take any health policy decision. And we can also link intermediate to the final outcomes and generalizing to the other settings. Like for example, some study conducted in India, let us say, we can apply this to Thailand because all are like lower middle income countries. They are at equal, economic level. So some high income countries they conducted in Spain, they can use it in European countries or other European countries or US also. Okay, so this is how we can generalize settings. And the synthesis head-to-head comparison where trial is not possible. For example, in the literature, there is a comparison between drug A and drug B, and drug B and drug C. So there are two different RCTs available. Now I wanted to conduct an economic evaluation where I wanted to compare A, B, C together. I can do that in my HTA or economic evaluation study. Got it? So this is a simple decision tree. Okay, where you can see the disease. For example, somebody diagnosed with diabetes. So there is a deficient node here. Either you will give intervention A or no intervention. So usually we will give some intervention. So let us say intervention A and intervention B. After giving this intervention, there is a chance node. So patient can have some different events or may not have any events. For example, somebody diagnosed diabetes at 50. They are very compliant to the treatment regime. So there will not be any adverse events happens, right? So if somebody is not compliant, what will happen? It will lead to retinopathy or kidney failure, right? So accordingly, you have to decide. So this decision tree is basically a linear model, like unidirectional. So best examples are like infectious diseases. Infectious diseases, it comes, you treat, it gets cured, right? You don't, it will not come back usually, or it comes back after exposure episode, right? So these are very short periods. So we use decision tree where the timeline is for a short period of time. Like, okay, dengue. Let us say dengue. Somebody diagnosed with dengue, you treat, they will be cured. Otherwise, they will die. Right? So that is it ends with the terminal node. So there will be one more arm where the people die. So you have to consider it in the death or if there are some events happening or any termination like cure. Okay. So this is how you have to develop the model. So again, you can develop this model based on the literature available. Okay, and the natural history of disease. So this is an example. So there is some pharmacoeconomics of chip therapy. So now you cannot say you don't know toxic therapy. What is toxic? Why we use toxic? What are toxics? I think from second year onward you should be able to know this topic. Nobody knows? Nobody? Any volunteers? NSAIDs, you know NSAIDs? You know NSAIDs? Any example? Paracetamol, aspirin, all these are NSAIDs. So why we are not giving NSAIDs? Sometimes we give preference to the toxic therapy. No, but why? Why toxic? Why not NSAIDs? I can't hear you. Toxicity? Any other? Toxicity, not toxicity, but what are the adverse drug events that can cause by NSAIDs? Peptic ulcers. So basically, toxics are selective. NSAIDs are not selective, these are non-selective. I think pharmacology people should be able to say this. So toxic therapies are selective, but it has its own side effects. It affects the cardiovascular functioning, if I'm not wrong. So yeah. So now they wanted to compare celecoxib with different combinations. One is NSAID alone, NSAID plus proton pump inhibitors, H2 receptor antagonists, NSAIDs plus misoprostol, diclofenac or misoprostol. So after that, there will be possible events. One is no GA adverse events. So in celecoxib you will not get adverse events because it is very selective. Okay, and again GA discomfort may happen with NSAIDs and symptomatic ulcer. So anemia with serious GA complications. After that, either survive. Okay. So there is a chance of occurring each and every event. So based on the probability, we will see what kind of event is happening at what percentage or the probability, chance. Okay. For example, in celecoxib, GA, no GA adverse event. So probability is 0. So the rest of the events may happen or may not happen. So again, you have to look for the literature available, and then you have to use this particular health states. Okay. So this is an example, and see, this is how the model goes. So these are probabilities basically. So 0.37, 0.07. So probability is either 0 or 1, right? Anything more than 1? No. So if you add these two, it will be 1. 0.3, 0.7, it is 1. So if somebody treated with non-selective NSAIDs, so there is a chance of problems is 0.7, GI problems 0.3. If toxics are there, again they have given a chance. Okay, don't go by numbers. This is how they have evaluated. Okay. So there is till now we have seen decision tree. So there is something called Markov model. In case of infectious disease, the events are happening in unidirectional, right? But in case of chronic diseases like hypertension or diabetes, people will diagnose with angina. Again, they will be normal, right? They cannot continue angina throughout the lifetime. Isn't it? Any disagreements? No, right? People cannot stay with this pain. So they will be cured. So they will come back. So there is a chance of coming back. Right? So when the transition is happening in the health states, so we can use a Markov model. So here the model assumes patient is always in one health state at a given point of time, which is referred to as Markov states. So I will show you a Markov model. So those health states are called as Markov states. And the event of interest are modeled transition from one state to another state. So what is the chance of moving from one health state to another health state? Like for cancer, okay, stage 1 to stage 2. If there are 100 patients diagnosed with stage 1 cancer, how many can go to stage 2 by the end of 1 year? Okay, so that's how the transitions happen, and the transition probability you can get it from literature. So this is a simple Markov model. This is one health state, so that is healthy or reoccurrence or death. So everybody will end up at death. So chronic diseases, one or the other day, everybody will die, right? So the chance of moving from one state to another state is your transition probability. So this is called absorbing state because everybody will die at one day, and this is the transition state or your Markov state. So this arrow says that people either will stay in this state or they will move to recurrent state or they will move to death. Okay. So these health states should be comprehensive, mutually exclusive. So one person cannot stay at two different stages. Have you ever seen anybody diagnosed with stage 1 and stage 2 together? No, right? So either they will be in one state or another state. So this is the one model that developed. You want me to talk about the research question as well? Okay. When you develop, I could see 2-3 head nods, so that's why I'm going into details. So when you develop a research question, you have to look for. So since beginning I'm telling there should be 2 alternatives, right? Let us see whether these alternatives are there or not. What is the cost effectiveness of tiotropium as add-on therapy to LABA plus inhaled corticosteroids for patients with severe persistent asthma? Okay, what is the population here? What is the disease? Severe persistent asthma. Okay, when you cannot directly say asthma because the disease progression would be difficult in asthma and severe persistent asthma. So that is why you have to be very careful while taking the transition probabilities or the literature that you are relying on. For example, you will look for RCT, you will find something in asthma, you cannot directly jump into the model and develop everything. Okay? You have to look for something that conducted in severe persistent asthma. So that is your population here. Okay? What kind of study it is? What kind of study design? Cost effectiveness. Okay? Cost effectiveness study. So 4 different types. One is cost effectiveness analysis. So we got study design of what? Tiotropium as add-on therapy to LABA plus inhaled corticosteroids. So these are the different interventions that we have. Then you have to plot the different key parameters that you have to list down in your study by developing protocol. Okay. So here we are using Markov model because there are reverse transitions, right? People can go to from this state to this state or come back again. Okay. Similarly here. So there is a reverse transition possible. That is why we have gone for the Markov model, not the decision tree. First one is decision tree. Okay. So what is your population? Population diagnosed with severe persistent asthma. So what is your intervention? So what is your intervention? Inhaled corticosteroids LABA plus tiotropium as an add-on therapy. So the existing treatment is this. So they want you to see the effectiveness of adding tiotropium. Okay. So this is your intervention. You cannot just try tiotropium. No, tiotropium alone is not using. We are using tiotropium as add-on to LABA plus ICS. Okay. Then you have your comparator. So lifetime horizon, as I said, in economic evaluation studies, you can run the model till everybody reaches death. And not going to detail. So societal perspective. So model outcomes would be your, in all the economic evaluation studies, it would be quality of life years gain or life years gain. Okay, these are the different outcomes that you look for in the economic evaluation studies. So this is another example where they have conducted some cost effective analysis. So again, they compared the autologous stem cell therapy to conventional chemotherapy for treatment of multiple myeloma in India. So they have written India. They have written India because it will determine what kind of cost we have to take. Perspective will change. If it is US, hospital bed cost will vary, right? So that's why they have written even geographical area. So what is the disease here? Multiple myeloma. Okay. So I just wanted to show you, it is not that either you have to develop decision tree or Markov model. Sometimes you end up developing a hybrid model like this. Okay. Just to sensitize you. So sometimes model can be as complex as this, but in general, what we say, model should be simple, comprehensive. It should be exhaustive. None of the models are correct. Okay, but some are useful. This is what they say. Because as much as you can include different health states, you have to include in your model. Okay? So now can you say some difference between clinical trials and economic evaluation? Or you will say first we should know clinical trials. Any warranties? No. So anyways, so clinical trials, after conducting clinical trials, what we will do? We will submit the data to CDSCO for the approval so that it will come into the market, right? So similarly in health economics, so that is why here the audience, the regulators or the clinicians who will prescribe your drug. Let me know if you are running out of time. Okay. And economic evaluation studies, it would be payers, like for example government wants to pay something, so accordingly the audience will vary. So the objective here is safety and efficacy, but in economic evaluation studies, value for money. So for every rupee spent, how much outcome you are getting in terms of enhancing quality of life. That's what you read or measure here. So outcome measures efficacy, as I said, does it work? Whereas in economic evaluation, it is all about effectiveness, efficiency. Okay, efficiency is when you read about cost as well as outcomes. Okay. So comparison, choose which treatment is better. So here it is incremental cost effectiveness ratio. I will show you in upcoming slide. So the time frame would be, as I said, in arthritis, the time frame would be very limited, like 10 years or 15 years. Even if you are conducting for 10 years, they will come up with some intermediary analysis, interim analysis, and they will publish it. So, but in case of economic evaluation, these are basically the timelines are longer than the existing RCTs. So that is why, although we have RCTs for generating the evidence, still we need economic evaluation studies. Getting? So what are the different estimates? For example, we have diagnosed some patient with the disease X. So either they can be treated with drug A or drug B. Okay. So what are the different effects with the drug A? Those are effects A, and for B we have effects B, and different costs that are involved. Costs like administration cost, bed charges. Okay, for purchasing syringes, medicine, everything. So similarly for drug B, then we can estimate the incremental cost effectiveness ratio. So it is the difference of cost between the two treatments divided by difference in the effectiveness of these two treatments. Okay. So although the formula looks very simple, okay, but it is not easy to calculate this, estimate this cost. Okay. So now we got ICMR value, some 2 lakh per quality gain. So whether government has to decide to invest on that or not, how we will decide? We got some figure only. How we will decide? Now we will compare this ICMR value, incremental cost effectiveness value, against the GDP per capita of India. So currently India is accepting whatever the estimate. I mean ICMR values usually comes as rupees per quality. Okay, how much amount you are investing to enhance one quality of life. So if whatever comes below this 1 GDP per capita, correct, 1 GDP per capita is 2.12 lakh or okay. So whatever comes below that value, that particular treatment will be considered cost effective. Okay. So I'm not going into the cost effectiveness plane. Sometimes you may have to end up drawing some cost effectiveness plane where these are the ICMR values we have to plot, and then we have to decide whether we go for it or not. For example, there is an existing drug metformin, some new sulfonylurea come into the market, whether to adopt existing health program or not. So this is the question. Okay, so we will estimate the ICMR value. So if ICMR value falls here, showing that less effective but more costly, will you go for it? No. So excluded. If something more effective but less costly, obviously we will go for it, right? Less effective, less costly. What we will do? Some are saying no. Any yes? Maybe we don't know. Maybe they are okay. There is always a trade-off. Maybe the patients are only affordable. Below poverty line patients are there. They cannot afford a high cost treatment. So since it is costly, but whether we can rely it or not, okay, we cannot afford less cheaper, less effective medicine at the cost of their health, right? So that is why sometimes you have to draw one line here. That is a threshold. So if something falls below that, then you will accept it. For example, if something is falling here, more effective, more costly, more effective. So no innovation comes with less price, right? Innovation takes billions of dollars. So morning sir was also saying. So, but thing is that it is more effective. Can I invest my income or not? Yes. She is saying yes because she has resources. Anybody? Any knows? Any maybe? Maybe? No? No? We can invest, but we have to check for the budget available for us. So again, so this line will decide whether we can invest on a costlier medicine or not, whether we can adopt the new technology or new drug coming to the market and be provided to the patients or not. Okay. So how we can translate this into policy making? The answer is your health technology assessment. So whatever the techniques that we are discussing now, it will be utilized in the health technology assessment in India. So this is a body. Okay. So I will tell you what is HTA first. Then we will talk about the health technology assessment in India. So what is HTA? HTA, what it does? HTA means it is a multidisciplinary process where you gather policy relevant evidence. Policy relevant. So when you collect the policy relevant evidence, you can inform the policy makers. Right? So what are the different aspects that you look at it for any technology? What is your clinical effectiveness of the drug? Okay. Then you look for the economic aspects, that is your cost. And then social and ethical issues. Whether we can give this to the whole public or not, or whether we can give this to the rural population or not. These are the different aspects that you look at when you do the HTA assessment. Okay. So medical and economic evaluation, it is same like a pharmacoeconomic study or economic evaluation, right? but it's something called social and ethical aspect that you will look for in HTA. Okay, and then you will take a call whether to use this health intervention or not. How we are performing this HTA assessment through a transparent, inclusive, systematic and robust manner. So there is a different method. I mean, the methodology that we are discussing, we will follow all this and to assist the policy makers in decision making while formulating the policies for what? Either to include a new therapy or exclude the existing one from the system. Okay, so basically why we are doing HTA? If there is a new technology coming to the market for diagnosis, for treatment, for prevention or anything else, whether to adopt it or not. So that is why we are conducting HTA. This is evergreen or not? You always need these decisions throughout the human life exists in this world, right? So this will keep happening. Health economics till today, there are very few in India who know these techniques. Okay, so that's how important these HTAs are, and I will try to throw some light on the AI-based technologies that are adopted after conducting HTA into the health policy. Okay, and then I will discuss about career opportunities in ICMR as well as in the department. Okay. So these are the frequently used terms, right? Have you read any articles? Anybody have habit of reading published literature? Anybody? No one? Nobody is raising hand. I would feel that nobody is reading. Very few. Very few. Okay. So have a habit of reading the articles even if you don't understand. Okay. For example, somebody is in the first year or second year of your career, like even if it is a B Pharm or Pharm, you will not understand. But try to make a habit of reading an article whenever you go to the library. Okay, then you will understand what are the different types of studies that are available, what kind of study is talking about what. At least you will understand. Then once you reach fifth year of final year of Pharm or even for M.Pharm graduates, now dissertation is a part of your curriculum, right? So it would be very helpful. So have you come across these words? Efficacy. Those who have raised hands. Any volunteers? Anybody wanted to say something about it? What is efficacy, effectiveness, efficiency? Is there any difference or not? First of all, yes, great. So what would be the difference? Anybody, any volunteers? Maybe we can pass the mic if somebody wants. Any volunteers? Can they use, as a synonyms? Yes or no? Yes? Yes. How many yes? How many yes? I heard so many voices, but nobody is raising their hands. Okay, these are not synonyms. Surprisingly, these are not synonyms. So efficacy is basically when you are developing a drug in your clinical trials, you will see the efficacy. Okay, efficacy is basically whether the drug is producing the desired effect or not. Okay, that's all efficacy means. Okay, but effectiveness is does it benefit or not? There may be some effect of the drug that may not be beneficial. If it is producing some effect, it is efficacious drug. But if it is beneficial, then only we can call it as an effective. Effectiveness is there for that particular drug. Okay. So the real effectiveness can be seen only in the field. That means your phase 4 trials. Okay. What is the other name for phase 4 trials? Because it is coming into the market. Okay, that is the real effectiveness of any drug can be seen in the field, not actually in the RCTs. But you can say that phase 3 trials they are publishing it as an effective drug. Yeah, they see effectiveness, they publish it as an effectiveness, but the real world evidence will give you a real effectiveness of any drug. So similarly, there is something called efficiency. So efficiency comes when you look for the benefits as well as the cost, how much you are investing and what are its effects. Okay, so this is where the health economics or economic evaluation comes. Okay, so what is pharmacoeconomics? It comparative analysis of alternative courses of action in terms of both their cost and consequences. So there are important words here, that is alternative courses of action. So there are comparisons. Okay, there is a comparison here, minimum of two. Okay, and again, what we are looking at, we are looking at the costs and consequences. Consequences means your outcomes. Okay, so when you look for outcomes, cost, and there is a comparison, then only such studies can be called as pharmacoeconomic studies or economic evaluation studies. Okay. So, what is economic evaluation? So, this is the science of measuring the cost and outcomes, okay, associated with the use of pharmaceuticals in healthcare delivery system. So, same, definition can be applicable to health economics also, but instead of pharmaceuticals, it will be like tech. Okay. So, the main objective is to improve the public health. This is what we have been discussing since morning, right? Through the rational decision making when selecting among alternative therapies. So I think you will appreciate this objective once in this session. Okay, how we are able to identify the best available alternative available in the market. Okay, so that's how we will also generate the treatment guidelines, formularies in the hospitals. Okay, so the healthcare needs are always high, sky high, right? During COVID also, we were struggling with the testing kits, we were struggling with the beds, right? And the cost has gone high, right? So the resources are always limited. So even in the developed countries, even for high income countries, the resources are always limited. So how effectively we can use this revision? How efficiently we can use these resources to get a better outcomes? So this is all about that. I mean the pharmacoeconomics or economic evaluation studies. So that we will inform the decision makers about the alternatives available. For example, to treat a diabetes. So what is the first line therapy for diabetes? First line therapy for diabetes. Sulfonyl ureas. Any other? there.